Hey everyone, welcome. Thank you so much for joining us for this virtual UMiami Health Talk. It is the latest on brain health and Alzheimer's challenges. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by the University of Miami Health System Department of Psychiatry and Behavioral Sciences Memory Disorders Clinic. The Memory Disorders Clinic provides compassionate care for individuals facing a wide variety of challenges and conditions related to memory. The center draws on the knowledge and experience of a multidisciplinary team of professionals at one of the country's leading academic medical centers. Because memory problems can have many causes, the team takes a holistic approach to assessing, diagnosing, and treating each patient. They know everyone is different, and the doctors are actively involved in leading edge clinical trials that may offer new options. To learn more about UHealth's Memory Disorder Clinic, visit umiamihealth.org/psychiatry and call 305-243-0214 to schedule an appointment. Do not worry, that information is going back up again at the end of our talk. And also, you're going to receive a recording of this conversation and webinar about a week afterwards. So all of you who are registered and listening to us tonight, you have an opportunity to rehear it again because there's a lot of good information in there. So tonight we're going to hear from a renowned memory disorders expert, Dr. Elizabeth Crocco. And at the end of the presentation, there's going to be a Q&A session. Now, this is a unique opportunity for you to ask direct questions of our experts. So use the Q&A feature at the bottom of your Zoom screen. Take a look at your computer, find it, and that's where you're going to enter your questions. So it's now my pleasure to introduce Dr. Elizabeth Crocco. She's a clinical professor and chief of geriatric psychiatry at the University of Miami Miller School of Medicine. She's also a medical director of the Center for Cognitive Neuroscience and Aging and oversees the Memory Disorder Clinic and community outreach for Alzheimer's disease and related dementias across South Florida and even into the Florida Keys. Her research focuses on reducing health disparities and improving access to geriatric mental health services for underserved multi-ethnic populations. Dr. Crocco leads the development and validation of neuropsychological and functional tools to detect early cognitive impairment and serves as a primary investigator on multiple clinical trials targeting Alzheimer's symptoms and disease progression. The geriatric psychiatry training director at Jackson Memorial Hospital, our expert trains and supervises fellows, residents, and medical students there. There are so many of you on tonight. I know that this is a hot topic of great interest, and friends and family of yours who are probably affected by this, and if not, you want to know more about it. So let's welcome Dr. Crocco tonight, and let's listen intently and carefully, and whatever questions you have, please do jump onto our Q&A session. Dr. Crocco, it's all yours.
Oh, Ileana, thank you so much for such a lovely, lovely introduction. It is my absolute pleasure to be here today. For those of you who don't know me, my name is Dr. Elizabeth Crocco, and I have had the pleasure to work here at the University of Miami Miller School of Medicine for almost 28 years. It's hard to believe. All these years here in South Florida. And I have been treating patients with Alzheimer's disease and related dementias for probably about that length of time. And I've been the medical director of the Memory Disorder Clinic. And I want to be able to share with you today. This is my third year doing this, and today it's going to be a little bit different. The title of this talk is The Latest on Brain Health and Alzheimer's Challenges. And I really want to focus today on our changing and aging population. And I want to talk a little bit about the aging brain, but I also want to focus on what's new in Alzheimer's disease when it comes to early diagnosis and treatment, which has been very exciting in the last 2 to 3 years. So my first slide talks a little bit about our changing population. By the year 2030, 1 in every 5 residents in the United States will be at retirement age. The country will add 500,000 centenarians, and people 85 plus will triple. And so the question becomes, as we live longer, we want to be able to live better. So we don't want to just live to be 100. We want to live to be 100 work with our brain and our body intact, how we want to spend those years. So our talk today is about the brain and brain health. And we want to be able to optimize brain health to be a successful aging person that can be independent and happy. Reducing the risk of cognitive disorders such as Alzheimer's disease is as important as other things such as managing our hypertension, managing our diabetes, etc. So in years past, I've talked about how to make the brain healthier. And we're going to mention that briefly, but I really want to focus at those people that are at a greater risk for the disease that is the most common to cause cognitive disorder or dementia in the ages of over 65, and that is Alzheimer's disease. So what are some of the predictors of risk for people over 65 in getting Alzheimer's disease? So things will include how severe their cognitive impairment is and how frequent the problem is. Those people who have vascular risk factors, such as high blood pressure, diabetes, hyperlipidemia, who still smoke and live a sedentary lifestyle. People who have had a history of significant head injury in the past. People who have genetic risk for ApoE4 carrier status, which we're going to touch on a little bit more. And then those who have recurrent psychiatric illnesses, such as depression and anxiety. When you have a combination of these predictors of risk, it puts you at a greater chance and likelihood of developing the disease. So I want to specifically talk about blood markers for the genetic risk. So some of you may have heard of the risk of an ApoE4 gene. So what is this a gene for? This is a gene for a protein that we find in our cell membranes that transport lipids or fats from different parts of different cells. And you in terms of your genes, you inherit one gene from your mother and one gene from your father. And those individuals that inherit this ApoE4 gene, which is an E4E4, are 14.9 times more likely to develop Alzheimer's disease at 65 or older. Whereas people who have other genotypes, such as an E3 or an E2, are less likely. This becomes important, not because it is absolutely means that just if you have this ApoE4 gene, that doesn't necessarily mean that you're absolutely going to get Alzheimer's disease, or that if you don't have the gene, you're absolutely not going to get Alzheimer's disease. But it is important when we talk about the treatments that are now available to modify the disease. So one of the things that we focus on, both in the Memory Disorder Clinic and in the Center for Cognitive Neuroscience, where I am a scientist and a clinical researcher, is understanding that the earlier we detect this disease process clinically, the better our chances are of modifying it and making a difference in treatment and management. So therefore, the earliest detection of those individuals at risk for Alzheimer's disease who are just beginning to have symptoms is really a priority to make a difference. Because once a person has the disease and has become more impaired in a moderate to severe level, it's very difficult to modify the disease at that time because the brain has really undergone brain failure and a lot of degeneration that is difficult to reverse. So the earliest detection is going to be paramount. We've been very lucky here in the United States that we recognize Alzheimer's as an important thing we want to research. and the amount of federal funding that goes into this research is direct proportion on how successful we will be. So some examples are things like breast cancer or HIV/AIDS. The amount of money that we put into finding, understanding the disease, researching the disease, and coming up with excellent management and treatments has led us to have great breakthroughs in treatment, and we're very hopeful for Alzheimer's. I just want to mention briefly this diagnostic mild cognitive impairment. Many of you, I'm sure, have heard this terminology. And this is sort of an in-between between normal cognitive aging and somebody who has something called dementia, right? Which is a clinical syndrome which has cognitive impairment and a lot of functional impairment. Mild cognitive impairment is important, and it's usually mild memory change from baseline. These are people who normally function. They're able to take care of all of their activities as normal. We call those ADLs and IADLs. They can dress themselves, groom themselves, they can still drive, they can still handle their finances, prepare a meal. They function normally. But on diagnostic testing, they are noted to have something called amnestic MCI, or a memory impairment that the clinicians pick up on objectively that may be somewhat worse than we would expect for somebody of their age, normally in normal aging. And typically, when you come to a person like me, who is an expert in memory disorders, to a memory disorder clinic, we evaluate you so we can tease out whether or not we put you into this realm of mild cognitive impairment or not, or whether it's more normal aging, which is important clinically in our ability to diagnose things like Alzheimer's disease. Now, when you progress, there are certain patients that have something called a major neurocognitive disorder, or what we used to call dementia. And dementia is not a part of normal aging, and it usually causes dysfunction. It causes cognitive dysfunction, such as in your memory, which is very common in diseases like Alzheimer's disease. But it can cause other symptoms, such as neurological. So if somebody has a Lewy body or Parkinson's type of dementia, which also can cause cognitive impairment, can cause also neurological signs and symptoms, such as tremor and difficulty walking. You can also have psychiatric disease and psychiatric problems as part of the dementia. We most commonly see dementia in the elderly, and it can have many different causes. So when you come to a memory disorder clinic, or you go and see a neurologist or a geriatric psychiatrist, typically the dementia workup that's performed includes getting a history, talking to a corroborative loved one so that we can understand objectively if someone else is noticing problems. And they undergo cognitive testing. Usually there's some form of neuroimaging, such as an MRI of the brain, some routine blood work, and sometimes an EEG. And this is your traditional dementia workup that we still do to this day, that helps us to really look at you to understand, are you having the cognitive problems that we suspect, maybe in the MCI or dementia range? From the imaging, can it tell us a little bit about whether or not you're having vascular disease or other biomarkers that may suggest other types of illnesses that we can potentially manage or treat? And then routine labs that may be causing the problem. So this is a traditional kind of workup. But things have been changing, and they've changed a lot in the last 2 to 3 years. And the reason they've changed is that we now have brain biomarkers used to detect different types of dementia. And what we're going to focus on today is the dementia of Alzheimer's disease. So we do have now FDA-approved biomarkers to be able to diagnose Alzheimer's disease based upon its pathology within the brain. So on the star that you can see here on this list, the first and the gold standard that we use is the FDA-approved amyloid PET scan or PET CT scan, which measures beta amyloid pathology or amyloidosis in the brain. When you have a positive amyloid PET scan, it means that you have the pathology of amyloid that signifies Alzheimer's disease. There are other brain biomarkers that we look at. We often look at biomarkers on an MRI, looking at decreased brain volume in certain areas. We also can measure tau or phosphorylated tau through the CSF, through a lumbar puncture and fluids that demonstrate certain protein accumulations that really are circulating from the brain in the periphery. And we also have a tau PET scan, which measures tau, which is another protein that's not specific to Alzheimer's disease, but in the course of our evaluation as a clinician can help us to better diagnose whether or not you truly have Alzheimer's pathology. So that sounds like a lot, right? Lots of brain scans, lots of doing a lumbar puncture. These things are very expensive, and they also tend to be somewhat invasive when you think about a lumbar puncture. But now we have evolving something called plasma biomarkers or blood biomarkers, understanding that there are certain proteins in the brain, such as amyloid and tau, like phosphorylated tau and total tau, that we can measure in the blood, in the periphery, that can be very helpful in identifying those patients that have Alzheimer's disease. They consist of, the top ones that I want you to be aware of are amyloid, phosphorylated tau, which are looking at these pathological proteins that compromise amyloid and tau within the neurons, and other plasma biomarkers called neurofilament light and GFAP, glial fibrillary acidic protein. These are just four. There are many other biomarkers that we look at in research, but these are four that commonly clinicians who are experts like me are utilizing on a clinical basis to kind of conceptualize whether or not somebody has Alzheimer's disease. The NFL and the GFAP, NFL is more of a measure looking at abnormalities within the cell when the neuron is breaking down, and GFAP is more inflammation in the brain that are not specific to Alzheimer's disease, but again, are part of a cascade of events that we usually see pathologically. So this literally has just happened this year. There's finally a blood test that's been FDA approved for the diagnosis of Alzheimer's disease, and it occurred in May. And it is the combination ratio of phosphorylated tau, p-tau 217, divided by beta amyloid 42. It's a ratio that is utilized that shows a 91.7% of individuals who are evaluated by an expert like myself, who is beginning to have the clinical symptoms of cognitive impairment and other things of Alzheimer's disease. If there's a positive result, it has a 91.7% chance of us being able to say this person has amyloid pathology. And it has a 97.3% of individuals with negative results to say, no, this person does not have amyloid pathology, and the chance of this being Alzheimer's pathology is close to zero. So it's important for me to tell you that these are now available. Many of them are covered by Medicare, and experts like me are utilizing them in a clinical setting. It is important for you to understand that it is not a screening test. I'm going to repeat that. These blood tests are not screening. This is not like a PSA or a prostate-specific antigen, where we measured as a screen for somebody who has no symptoms, just because you're getting older and we want to make sure you don't have prostate cancer. These are biomarkers that we do not at this time recommend for someone who's over 65, who feels okay, who's doing okay cognitively, and who undergoes an evaluation and the doctor says you're okay. We think you're just normal. This is really for someone who is beginning to have the feeling of subjective, there's something wrong, and they go to an expert like me, and I order it as part of their clinical presentation. So it's not ready for prime time yet. It's not ready for primary care yet. This is really still the realm of experts like me, but it is available, and it is FDA approved. I want you to look at this other slide now that talks about cognitive stress tests. One of the special things that we do in my memory disorder clinic, or our memory disorder clinic at the CNSA, is that we use special cognitive stress tests that are designed to challenge a person's cognitive symptoms, and we can really identify very subtle memory deficits in people who just have the earliest kind of feeling that their cognition is impaired, even before they have that mild cognitive impairment designation. And we're very lucky to have this test because it helps us to be able to evaluate you in the clinic fairly quickly and efficiently without you having to go through more extensive cognitive testing, which can take several hours. We're working towards a way to develop it to become more time efficient, sensitive, and specific, so that this could be really something given to your primary care doctors and other physicians to better diagnosis. And this just has the name of it. It's called the Lassie or the Lowenstein-Acevedo scales for semantic interference in learning. So I don't want to go into great detail of how we do this. That's talk for another time, but it's nice to know that we have some of these things. I just want to briefly mention about, I've always talk about, as a geriatric psychiatrist, I can diagnose Alzheimer's. I'm an expert. We can do the blood biomarkers and we have lots of treatments, but it's also important to recognize that over 90% of patients who do develop Alzheimer's dementia can have psychiatric and behavioral problems, such as aggression, depression, anxiety, agitation, sleep disturbances, and even psychosis, such as hallucinations and delusions. And sometimes, our ability to manage these things can really improve a person's quality of life. And it can also help to adjust and manage the disease so that it doesn't decline as quickly as not having these behavioral symptoms. Just a brief mention that there are medicines to avoid in the older. A lot of times patients come to me, they're like, should I be taking that statin? Should I be taking this? These are really the drugs that you want to avoid in patients over 65, particularly if you have Alzheimer's disease, but even if you don't. These are the drugs, they don't cause Alzheimer's disease, but they certainly can add to the burden of causing cognitive impairment, confusion, as well as gait disturbances and difficulty walking and other problems. And they include anticholinergic medicines such as diphenhydramine and oxybutynin, which are commonly used for sleeping difficulties and or urinary problems, sedative hypnotics, benzodiazepines such as lorazepam or alprazolam, and then opiates. So these are really the red flag drugs that we want to avoid. So I'm going to jump ahead because I really want to get to the questions. But before I get to the questions, I do want to talk about treatment and management of Alzheimer's pathology. The old pharmacologic or medications include cholinesterase inhibitors and NMDA antagonists. Cholinesterase inhibitors They basically increase a neurotransmitter in the brain called acetylcholine. They've been around for 25 years. They are FDA indicated for mild, moderate, and severe Alzheimer's disease. And then NMDA antagonists, such as memantine, which are FDA indicated for moderate to severe Alzheimer's disease. These medicines can be very useful. They do not modify the progression of the disease, but they can, for a short period of time, 6 months to 2 years, improve some of the cognitive and the functionality of the patient. But these are very moderate at best. I want to talk for the last couple of minutes about the two new FDA-approved drug for the treatment of Alzheimer's disease that actually modify Alzheimer's pathology. They work very differently than the other drugs that I mentioned that just target select neurotransmitters. These are the drugs that actually clear the amyloid plaque and the amyloid deposition out of the brain, which is the leading cause of Alzheimer's disease. And they are called lecanemab and donanemab. Those are the names of the drugs. They have demonstrated a marked reduction in amyloid deposition in the brain. And it usually takes 6 months to 18 months of this treatment for it to occur. They do work a little bit differently. The lecanemab tends to clear out the amyloid that is soluble, that is the new amyloid, or the amyloid that's being laid down quickly. Whereas the donanemab tends to get rid of the amyloid plaques that has already been there for some time. So they work a little differently, and that's important. They have both been demonstrated to clear amyloid. Donanemab does it a bit better because it clears out that older amyloid. They both are drugs that have been demonstrated over an 18-month period to modify the disease so that patients don't get worse as quickly as they would without the illness. Because remember, Alzheimer's is a progressive illness. So they still progress with these drugs, but at a less rapid rate. These are not pills. They are infusions. So you have to go to an infusion center for them. The first drug, which is lecanemab, you have to go twice a month. The second drug, which is donanemab, is once a month. They are infusions. And because but they do an excellent job of clearing the brain of amyloid, and they've been demonstrated that. They do have the potential for side effects. The most important side effect for you to understand is something called ARIA, or amyloid-related imaging abnormalities, which causes swelling in the brain, as well as the deposits of hemosiderin, or small blood deposits. It makes sense why this would be a side effect when you think about what these drugs are doing. They are entering the brain to clear out the deposition of these proteins by opening up the blood-brain barrier and clearing them out. And so as they perform these, it's going to make a leaky brain that in some patients will cause some swelling from the leakage and a little bit of bleeding through the vessels. So when I explain it that way, it's understandable why this could be a side effect. Now, does every patient get this? No, no. There are certain patients that get it that are more at higher risk. And now that it's been utilized for the last 2 years, one of these drugs and a little less for the other drug, if the doctor does a good job in targeting the right patients, the chance of these side effects are less than we would see in these clinical trials. So in the clinical trials, ARIA occurred in 12.6% of participants, and it occurred, though, in a higher incident. And remember when we talked about those genetic people, patients that had ApoE4, those are the ones that are more likely to have ARIA. Symptoms of ARIA can run as wide as no symptoms, where the person has absolutely no symptoms. It's just picked up on the MRI scan. But it also can lead to severe illness, coma, and death in a very small percentage of patients. As I mentioned, these treatments are offered for typically an 18-month period. The lecanemab is offered continually in a maintenance phase because it has to continuously remove the new deposition of soluble amyloid, whereas donanemab stops once you have a scan or a test that says your amyloid is gone in your brain. Eligible candidates include those individuals that have the earliest form of Alzheimer's disease, such as MCI or very early dementia. That is why it is so important for individuals, if they are having cognitive impairment, to come and be evaluated, because there is a window of opportunity to get these treatments. Certain patients are not eligible for treatment, particularly if they're on anticoagulation therapy or if they're not eligible for MRI. That's the best I'm going to do, and I'm going to look forward to all of your questions because I'm sure you have a lot. I wanted to keep this very basic and simple, and I just wanted to let you guys know that at our memory disorder clinic at the University of Miami, we are here for all individuals with cognitive impairment, Alzheimer's disease, and related dementias, and their families to help with everything. Thank you.
Thank you, Dr. Crocco. Always incredibly informative, and there's so much to unpack here. So we see the questions coming over from people saying, how early can Alzheimer's be detected? How early can I go and benefit from these amyloid removing medicines? So let's get right to that. Do you have to be symptomatic? Can you do it for screening?
So that is perfect question. So you have to be symptomatic, and I'm going to explain why. When you have amyloidosis, when you have amyloid in your brain, you have Alzheimer's pathology, either from a PET scan. That's the gold standard. But let's suppose you have no symptoms. We don't know, as clinicians and as researchers and as experts, we don't know what that means, because it could mean that you become symptomatic in a year. It could mean that you become symptomatic in 10 years. It could mean that you can go the whole rest of your life and not be symptomatic. And research into lowering the amyloid in asymptomatic people was not good. We did that research study. We've done those Alzheimer prevention trials. It wasn't until a person became symptomatic with cognitive impairment that we saw the improvements occurring. So that's really important. That's why we don't screen people, because the treatment is not working for them. They have to be symptomatic. And it's one of the reasons why in the CNSA and at my clinic, our main focus and our mission is to be able to pick up the symptoms that you have as early as possible, because that will give us the best chance to slow and modify this disease. So I hope that's understandable.
It is. Now let's get into what you consider to be symptoms and what we, the lay public, oh, I lost my keys again, I can't locate my cell phone, and serious things to be concerned about that you yourself detect and that the family members or people around you detect. Which would those be that you would identify?
So the first thing that's really important, and again, I think a lot about my patients. I think a lot about the people who have volunteered to do research with us. to give you an examples, I have a lot of family members, right? Who are reaching 60, 65. They took care of a loved one with Alzheimer's, right? They know they have a genetic risk. They have other risk factors. And they start to feel that, oh, my memory's not as good as it used to be. And they come for an evaluation. And they
Mhm.
come for an evaluation. So I think the first thing you have to look at is your risk, right? So sometimes family members come to me and they say, I want to look at my risk. Well, how old are you? You're 45. You got to wait because the chance of you developing symptoms at 45. But once you hit 60, 65, and you start to feel subjectively, I feel like my memory's not as good as it used to be. And it's consistent. Then might be the time for you to go to your primary care doctor and say, look, I have this complaint, and or go to a memory disorder clinic. That's because you have to allow the experts to do the evaluation to be able to say, well, you're fine.
Yeah.
Versus, well, maybe you are having that mild cognitive impairment, and we should do the amyloid tests and we should consider treatment.
Yeah. So here's a question that comes over now. This person is not giving us the benefit of his or her age, but says, my mother and aunt had Alzheimer's. Should I be eligible for genetic testing? Would that be the first step? I'm concerned because I have some symptoms, or at least I think I do. So here we're back to the symptomology of what we think is normal or abnormal and what you as a professional. So what would you say to this person?
So I want to talk to you about the genetic part first. We don't, as clinicians, as experts, recommend for you to do those ApoE tests out of the blue. We don't recommend it because if you're negative and you don't have that higher risk of the ApoE4, that doesn't mean you're never going to get Alzheimer's disease. You could still be, we call them a sporadic. You can still get Alzheimer's disease. And if you're positive, doesn't mean you're absolutely going to get Alzheimer's. That's why if you're younger and you're asymptomatic, we don't recommend that because it's just going to make you worry about nothing. But if you are having symptoms, you need to be evaluated. And one of the things we do in the community, and many memory disorder clinics do this, and we do it at the YMCA sometimes, we do it at senior centers, we do it at a lot of different locations, is we screen people in the community. And we do a brief screening test with experts that say, maybe you should come. And you
Mm.
should come to the memory disorders, or you should go to your primary care doctor and say, I don't, I think that I need a further evaluation, because you need that evaluation to come up with that proper diagnosis of mild cognitive impairment.
You said, Dr. Crocco, that the blood test, the plasma blood biomarker, is not going to be used as a screening test, not
No,
available.
not yet.
Not yet, but I think we're headed down that path because I hear the concerns of people saying we're aging, and we do know that some of the dementias are a product of abnormal aging. I'll give you that. But how about the home test? Are there home tests
Yeah.
that can differentiate this varied forms of dementia?
So there are no blood biomarker home tests available yet. You know, and there used to be years ago, they used to have a home test for the genetic testing. And anybody can go on what are those 23andMe and those, and oftentimes they will test you for the ApoE4. But there aren't really any home tests when it comes to testing for those biomarkers that are phosphorylated tau and A beta 4240. Those you would have to come to a clinician for them. But honestly, your primary care could order these. I don't recommend it yet. I have had multiple calls from primary care physicians who happen to order it, and then when they get a result, they call me up and they say, what do I do? What do I do? What does this mean? And I'm like, well, I really don't know what it means because I'm not quite sure what's going on with your patient. I don't know what their risk factors are. And I don't know what kind of an evaluation you've done. That's why we don't recommend it as a screener, because there's no way to interpret it unless you do it in the context of the full evaluation. That's why you still have to come to the expert for that.
And so let's go right into the question that you're asked all the time. What's the difference between Alzheimer's and dementia?
Yeah,
And I keep getting questions here in the Q&A box of, please, what's a symptom that's abnormal? Please
yeah.
tell me what's a symptom that I
So
should.
dementia is a syndrome. It's a clinical presentation whereby a person is having cognitive impairment. Most commonly memory, right? Short-term memory loss, they're forgetful, they but they can become disoriented. The person could have language difficulty planning things and carrying out tasks and thinking things through. And usually it's so significant that it really interferes with the person's function, and family members, loved ones, and care providers have to do things for them. They just can't do them anymore. And that's a syndrome. And there are but it's not a cause. It's just a clinical syndrome. But there are many different reasons that you can have dementia. You can have dementia at 25 because you have a severe traumatic brain injury. You can have dementia at 60 because you've had Parkinson's disease for a couple of years, and then all of a sudden you start to develop cognitive impairment. Somebody diagnoses you with Lewy body dementia. You can have a cognitive dementia after you have a stroke, right? So there are so many reasons that you can have dementia, but by far the most common that occurs after 65 is Alzheimer's dementia due to amyloidosis or amyloid pathology. That is by far the most common reason. That's the difference. That's the difference. And when you come to a memory disorder clinic or an expert, if you're having these problems, we tease out the cause. We have the ability to tease out what the cause of your cognitive impairment is.
Yeah. Whether it's a vascular dementia caused by a stroke or whether it's plain Alzheimer's where the amyloid is
Or
present.
Parkinson's disease, or even ALS. People who have ALS get dementia. There's
Yeah.
many different causes of dementia.
A couple of questions here on everyone's concern about the family inheritance. So here's someone who says, are you more prone to having Alzheimer's if one of your parents has it?
Yes,
This question.
unfortunately, yes, yes. But it doesn't guarantee that you're going to have it. That's the important part,
Yeah.
right? It increases your risk, but there's no guarantee that you're going to have it.
Okay, here's someone who asked, my mother has advanced Alzheimer's disease. She's been stable for many years. She walks, she's losing her speech, but she's functioning and always in a good mood. Would this medicine that you're talking about, the latest and greatest to remove the amyloid plaque, work for this patient?
Unfortunately, we don't know because it hasn't been studied in people with moderate to severe Alzheimer pathology. So the easy answer is we don't quite know. The feeling, though, my feeling as an expert and as a clinician is probably not, because she's already has brain dysfunction. However, it's really important when you say to me, and I'm speaking directly to this person, that my mother is in a good mood and she's able to do things and she's loved, and this is a very important message to everyone, because a lot of the times when I see people with moderate to severe dementia, I can't fix that. But oftentimes, if they are not happy, if they're depressed, if they're anxious, if they're agitated, that we can fix. And we can make them have a better quality of life. And that's important for those of you to hear when you have a loved one with more moderate to severe dementia. And they're also welcome in our clinic when you need help with that.
And here's a very interesting question that someone was paying attention. What's the difference between the neurologist and the psychiatrist? And so you cover the full spectrum, but which is the one is it both that diagnose?
Yeah, so when it comes to cognitive disorders, there are three types of physicians that are really the top of the experts. I should say clinicians, the top of the line. Neurologists, cognitive neurologists, geriatric psychiatrists, and neuropsychologists that specialize in aging. Those are the three groups of people, of clinicians, that are really the great experts when it comes to dementia, Alzheimer's disease, and cognitive disorders like these. You understand? So when you get a specialist like me who works in the at the University of Miami, this is a one-stop shop. So we do it all. We do the cognitive, we do the neurological, we do the blood biomarkers, the imaging, we interpret the imaging, but you get the added benefit of the psychiatry portion, which is to manage the anxiety, the depression, the behavioral problems, as well as our ability to give you behavior help and behavior modification to help the loved ones. We even provide help for care providers. We have individual psychotherapy and other referrals that we give you to help. So this is a one-stop shop that we can do all of it.
And the psychiatry portion of that, when you say manage, it also means perhaps with psychopharmacological assistance.
100%. So sometimes you need help with psychopharmacology, such as antidepressants or anti-anxiety agents, or agents that you need help because a patient has agitation or behavioral disturbances. We are the experts in that, 100%.
Let's talk about focused ultrasound for early stage Alzheimer's. Is that important, useful?
Yes. So this is a new thing. Again, this is still in the research realm. This is only in the research realm. This has not been done clinically, and they're still looking at clinical trials here. So I want you guys to understand this. But so the way it works, one of the things that we're understanding about Alzheimer's disease is that it's not just our ability to not have things like beta amyloid and proteins accumulate that cause disruption to the cells in our brain. But we also have to have the ability to clear things from our brain like beta amyloid, efficiently clear them out. Okay? This is one of the reasons why we believe that certain things like getting a good night's sleep, understanding, being able to combat things like high sugars and diabetes may be contributors to that and other things. So the idea behind having these pulses of ultrasound is a strategic and gentle way to open up the blood-brain barrier to be able to clear out better the things we don't want in our brain, like amyloid, and be able to bring in treatments or medications more effectively to the brain that can combat these things. There is also some thoughts that just by opening the blood-brain barrier through this ultrasound will help us to clear amyloid in patients who already have Alzheimer's disease. And they're looking at that. Some clinical trials are underway looking at that. It's the same with rTMS, which is transmagnetic stimulation. They're looking at that also. If you've never heard of it, this is basically, it's almost like an MRI. It's magnets to the brain to see if we can better clear these things. So these are, again, they're not ready for prime time. They're not ready for clinical, but they're actively looking at these things, along with a whole host of other clinical trials and different medicines and somatic treatments that target other things also.
But all the ones that you talked about this evening are FDA approved. There might be others coming.
100%, yes.
But yeah.
Everything I've talked about is FDA approved, yes.
The Q&A box is blown up. I think we're up to that.
That's why I'm glad I didn't talk that much.
But we're trying to go as fast as we can through. But let's go back to something you had said about amnesic memory.
Yeah, amnestic,
Oh, oh my gosh, I have that too. That happens to me. Is your memory getting short something that is of concern? Some of these are normal.
Yeah. So we do slow down cognitively as we age. There's no question. I always give the analogy when my kids are in their 20s now, and when they were teenagers, they're in their 20s. They're much faster at things. They learn better than me. They learn faster. They have better reflexes. They're able to focus their attention better. This is part of aging. We're not as good at those things. There's certain things we're better at as we age. We have more wisdom, experience, our language is better. But when it comes to memory, yes, can we be a little forgetful? A little bit, but it's very mild. It's very mild. Having significant forgetfulness and memory loss is not normal as we age. It's not. And it's not a part, my colleague, Dr. Curiel, I steal from her. She'll say, it's not normal for grandma, for abuela, that's not normal aging for her to be that forgetful, or for your mom or your dad to be that forgetful, where it's consistent. And you need to evaluate them. They need to come in for an evaluation. And the longer you wait, the worse it is, because there's only a window for some of these treatments. And you want to be evaluated for these treatments to make a difference.
Are there studies right now, this question from a patient at for patients with APOE4 that are currently going on that would be enrolling?
So I did put in for a grant, and keep your fingers crossed that we get this grant. We are very interested in looking at people who have a mother or father with Alzheimer's disease, who are between the ages of 45 to 65. We're very interested in you. And we want to be able to study you and follow you over time. And I think this is a very important group of people, people who don't have any problems, but they have that genetic risk with the potential for the ApoE4. So keeping the fingers crossed, I'm hoping to get funded for this so that we can start studying you, this group, and following you over time and looking at you cognitively to see what we're concerned about.
Let's talk about supplements. What can we do? I don't know if eating right or taking the right vitamins will prevent Alzheimer's, but what do we say to people
Yeah.
about all that?
I don't like to badmouth supplements, because there are certain times when supplements are useful to you. Obviously, when you have a vitamin deficiency and your vitamin D is low and this is low, you need to take, and the doctor says, look, your vitamin D is low, you need to have supplementation, or your bones are, you need certain D and calcium supplements because of bone problems. So that's absolutely, you need to do those things. However, it is a multi-billion-dollar industry, these supplements. And you got to ask yourself that question. What is it that we're achieving there? Okay. So if you're asking me, do supplements work when you have Alzheimer's disease and you already have Alzheimer's disease? The answer is no. They do nothing. Okay. But do they work to help you if you're just normal aging? Maybe a little bit. However, there are so many other things that you need to do before reaching for a pill. It's the easiest, I get that. And there's a long list of them, including physical activity. You can grow your brain with physical activity, mental activity that's challenging, combating your diabetes, losing weight, eating a healthy diet, not smoking, right? I had a patient came into my office the other day. He's like, I am taking a statin. I read somewhere this is causing my memory loss. So this was a patient who had hypertension, diabetes, and very bad cholesterol. And I said to him, that statin, along with your diabetes medicine and your antihypertensives, are doing much more controlling that and protecting your brain than anything you're reading about a statin. So you've got to put the focus where it's important. Cardiovascular risk factors, physical activity. I tell people in my clinic, if you can't do anything, just walk 20 minutes a day. Everybody can walk 20 minutes a day. right? So I talked a lot about opening up vessels, opening up the blood-brain barrier. Well, exercise, I promise, is going to open up that blood-brain barrier.
And
That's really what we want you to focus on.
you've always said that there's research that supports that. So this is not new, and this is not, a new drug. It's just common sense. But let's talk about these new drugs, the lecanemab and so forth, and the removing of the amyloid plaques. Is this the cure? I mean, are these infusions that are repeatable and so forth? Is it a forever? Will that patient not die of Alzheimer's or dementia?
That is a great question. And the honest answer is we don't know yet. When it does its job, as particularly the donanemab, it does its job. It gets rid of the amyloid. It absolutely does its job. But we only know what we know. We only know that these drugs have been available for about 2, 3 years. So we don't know in the long term what that's going to mean for patients at this point, and whether or not it's really going to make that major difference in slowing it enough that they're not going to die from Alzheimer's dementia in its moderate to severe phases. We don't know, but we do know that this is an important step in getting the treatments. And I have to tell the audience, it's very important for Ileana, for the audience to understand, it's a very personal choice whether you take these drugs. And I tell every patient this because there are some significant side effects that potentially you have to be aware of. And there are many patients that I have who say, I want to do everything possible to give myself the best chance, if I'm a great candidate, versus other people who are like, I'm a little nervous about these side effects. I don't know if this is right for me. So it's a very personal choice that you have to talk at length to. Any good doctor who's providing this, as we do in the clinic, is going to have a deep discussion with you about it.
We're of course running out of time because this is a topic that could go on for 4 hours. But I think in 30 seconds, if you could, Dr. Crocco, there's a lot of questions about younger people being on sleep medicine like Ambien and clonazepam, a 50-year-old. And should they go off of these things? I mean, they're concerned. It's prescribed, but should they stop these things as they're getting older and concerned about what you just said, that these drugs could contribute
Yeah.
to?
That's a whole long talk, but I'm going to do it in
Yeah.
30 seconds. Drugs like benzodiazepine and sleep medicines, they're really most effective in the short term, meaning that they're most effective when they're used for less than 3 months. Okay, right? Because the idea is not to use these drugs as a band-aid that you stay on and on for months and months and years, but to fix the problem. Right? They give you symptomatic relief, and then you fix the anxiety, you fix the sleep problem, and then you don't need it anymore. That's in an ideal world, right? That's an ideal world. So for those of you who want to come off the drug, you absolutely can, through different treatments, to treat your anxiety, your depression, and your sleep disturbance in a different fashion. And you need a good therapist and a psychiatrist to do that. That's my
Well,
short-term answer, and
that
they
was great.
and they absolutely should come off them.
Thank you. And, 88, 89 questions right now. So what we would say, since we have, a minute and a half left, is that this talk is specifically for what you're saying, to identify people, to have people say, I need to be screened. I need to
Yes.
come to a clinic such as yours. And if I have the symptoms or if I have the family history and so forth, that your take home message, Dr. Crocco, here? We can't solve it here in the next minute, but
100%. You don't want to wait. And I think that there are a lot of people out there that are frightened. They're afraid. They're nervous because they're afraid they're going to be told that they have Alzheimer's disease. And my answer to that is, I think that most of the time when people get evaluated, they're very happy to have gone through the process, whether they get that diagnosis or not. It's very rarely that somebody is not made happier by undergoing this process. And I think that's important for them to know because it is scary. I get that. but it's important to know
Yeah.
because we can make a difference.
And especially now that we are on a new frontier of treating. The cure word is nowhere in the vocabulary, but the treatment and maintenance and giving a better quality of life. So, Dr. Crocco, I cannot thank you enough for the privilege of your time. The University of Miami is so grateful to you and, of course, to this interactive audience that hopefully has learned something. There's more to gain and to be educated, and we appreciate that. So, the talk is over, but they can please reach out to the numbers we're going to put on the screen and there you go. You can even scan the QR code for the U Health Psychiatry and Behavioral Sciences, and to get an appointment, it's 305-243-0214. There's the website, umiamihealth.org/psychiatry. And Dr. Crocco and her team are here for you. Please fill out the survey. Please give us some feedback. I'm sure it's going to be, wow, I really learned something. So, Dr. Crocco, thank you as usual. Thanks for being with us tonight.
Thank you so much, Ileana, and it was an absolute pleasure to be able to be here for everyone.
Thanks, everyone. Good night. Stay well, stay healthy, and we'll see you again on the screen another night. Good night.